Chapter 9, Skeletal System, Articulations, Part 2. So we're now going to move on to the different kinds of movements. So first up is the gliding movements, also known as side to side or back and forth. Again, this is most common between plane joints where you have two flat surfaces coming together, and it just allows for a slight bit of movement in one direction. So as gliding movements. Then we have the angular movements. Angular movements include flexion and extension. Basically, if you think of the fully extended arm held out straight as being a straight line, that means there's a 180-degree angle between the forearm and the main part of the arm. And then as you bend at the elbow in this case, you're going to be decreasing that arrow. So you go from 180 to 100 to 90 and so on. So the way it works is flexion means you're decreasing that angle. So you're making the distance between the two parts that are moving smaller. And with extension, you're increasing the angle. So when you're moving the forearm closer to the arm, that at the elbow joint, that is flexion. When you're moving the opposite direction, so the forearm's going away from the arm, that is extension. Flexion, extension. And this occurs at a lot of joints. Lots of joints engage in flexion and extension. The wrist joint can do it, the fingers, the toes, the knee joint. You can laterally flex, bending the vertebral column. The yes-no movement of the head, nodding yes-no. I'm sorry, nodding yes, just yes. Nodding yes movement is another example of flexion and extension. And also hyperextension. What's hyperextension? Hyperextension is when you go past the 180. So if standing up with your head straight is 180 degrees and bending at the neck forward is going to be flexion. So it's going smaller down to like 90 or so degrees. The opposite way, moving your head backwards, that would be hyperextension. So going from 180 to 220, sure. So lots of places flexion extension, a few joints like the head nodding yes or the shoulder and hip joints can allow for hyperextension. Then we have abduction, adduction, also an angular joint. This time you're moving the structure, the limb or whatever, so that either the distal end of the limb is moving further away from the midline, so that's abduction, or the distal end of the limb is moving closer to the midline, and that's adduction. So abduction away from the midline, adduction toward the midline, and also you can think of it as abduction moving above, AB, adduction moving down, D. Try to keep these two terms clear in your head since they're only one letter different. So abduction, adduction occurs at the glenohumeral joint, the shoulder joint. Abduction, adduction occurs at the coxal joint or hip joint. Occurs at the wrist, occurs with the fingers spreading out and coming back together. So a lot of joints engage in abduction, adduction. Not as many as flexion, extension, but still quite a few. Circumduction. Circumduction is basically a combination of abduction, adduction, and flexion, extension, hyperextension. So joints where you can actually cause the end of the limb or structure to move in a big circle is circumduction. So you can do that with the glenohumeral joint, with the coxal joint. As we know, you can kind of do that with your head. You can engage in circumduction. Although there you're actually combining movements from two different joints, but that's all right. All right, rotational movements. Rotational movements means that the bones are rotating around a fixed axis. So for instance, rotational motion would be atlantoaxial joint, the joint that lets us turn our head to say no. Again, pivoting around the dens. We also can have our shoulder and hip joints allow for lateral medial rotation, so the arm or leg rotates out laterally or in medially. You can see that really well when the elbow is flexed partially. If you don't believe me, give it a try on your own. outwards, lateral rotation, inwards, medial rotation. All right, you didn't see that. Okay, other rotational movement is pronation, supination. This only occurs at the radioulnar joint. That's the joint between the radius and the ulna. And this allows us to twist forearms so that the palms are either facing forward, anteriorly, or backwards, posteriorly. So supination is when you turn the forearm so the wrist face anteriorly. Pronation is turning it so the palm is facing posteriorly. Some other special movements that are out there don't quite fit in the other three categories. We have elevation depression. So elevation depression, for instance, we can elevate our shoulders. This is actually elevating the pectoral girdle. So you move the pectoral girdle up, that's elevation. Pull it down, that is depression. Elevation, depression. You can also elevate and depress the mandible, allows us to chew. And then we have protraction, retraction. Protraction, moving the structure anteriorly or forward, and retraction, pulling it back posteriorly. So we can do that with the mandible, protract, retract. We can do that with the pectoral girdle, protract it, retract it. Just to note, again, we are elevating, depressing the pectoral girdle, not the shoulder joint. Even though the shoulder joint is getting moved, movement is not occurring at the shoulder joint. All right, opposition reposition is a movement of the thumb so that you can pull the thumb around in front of the palm so it's able to touch the fingertips, or pull it back so it's no longer in front of the palm, no longer touching the fingers. So opposition, reposition. Why does it get this special movement? Well, because it's the movement that lets us grab things. On the feet, at the ankles, we have inversion, eversion. Inversion, turning the foot so the sole of the foot is facing inward toward the midline. Eversion, turning the foot so the sole of the foot is facing outward or laterally. And then we also have dorsiflexion, plantar flexion. Dorsiflexion, moving the foot sort of superiorly, so the toes and foot are going up. Plantar flexion, moving the foot downward or inferiorly so that the toes and foot are pointing down. So dorsiflexion up, plantar flexion down. Turns out dorsiflexion is technically a form of extension, which makes me really annoyed with the name, but it is what it is. All right, now we're going to go through some specific joints whose names and general structures you'll need to know. First up, the temporalmandibular joint, the joint between the mandibular fossa of the temporal bone and the condylar process of the mandible. Mandibular fossa, condylar process. There's also an articular disc, a piece of fibrocartilage between the two bones. So that is also important to remember. And of course the ligaments, lots of ligaments holding the bones all together. And the temporalmandibular joint allows for depression and elevation, allows for protraction and retraction, and also lateral displacement. You can move your jaw side to side. So a lot of motions at this modified hinge / plane joint. All right, then we have the glenohumeral joint, also known as the shoulder joint. Glenohumeral joint, you have the head of the humerus fitting into the glenoid cavity of the scapula. There are tendon sheaths around some of the tendons. You have some bursae present. And of course, ligaments, always ligaments attaching the bones. You have articular cartilage lining the surface of the bones. You have the joint cavity filled with synovial fluid, the articular membranes. So all things you expect to find in all synovial joints with the addition of tendon sheath and bursa. The movements that occur at the glenohumeral joint include abduction, adduction, circumduction, extension, flexion, hyperextension, and lateral and medial rotation. And sometimes this very mobile joint gets dislocated, so that's when the humerus's head is no longer fitting properly into the scapula's glenoid cavity. And when that happens, obviously you have to get your humerus repositioned and placed back into the glenoid cavity. All right, the elbow joint, just called the elbow joint. Again, here we have the capitulum of the humerus articulating with the head of the radius. We have the trochlear notch of the ulna the trochlear notch of the ulna articulating with the trochlea of the humerus. We have ligaments. We have articular cartilage on the surface of the bones, the articular capsule, the synovial fluid, the joint cavity, all the things we expect to find at a synovial joint. Elbow joint is a hinge joint, so it allows only for flexion and extension. We have the radiocarpal joint, radiocarpal between the radius and the carpals. So it includes the radius, the lunate, the scaphoid, and the trichatrium. This is basically the wrist joint. It is a condylar joint. It includes those bones, articular cartilage. There's an articular disc, lots of ligaments. And it allows for abduction, adduction, flexion, extension, and circumduction. We have the coxal joint. Coxal joint is the hip joint where the head of the femur fits into the acetabulum. Again, we have lots of ligaments. We have the bones themselves, the articular cartilage, the articular capsule. And this ball and socket joint allows for abduction, adduction, circumduction, extension, flexion, hyperextension, and medial and lateral rotation. All the movements you expect at a ball and socket joint. There is also a labrum. So there's an acetabular labrum. This is a little extra bit of cartilage that goes all the way around the depression, the acetabulum, as it were. That increases the ridge, increases the contact between the two bones, the joints, more strongly connected together because of the acetabular labrum, the extra bit of cartilage going around the top of the acetabulum. And then the knee. And in the knee, we're going to learn the names of everything. So, of course, the femur with its lateral medial condyles, the tibia with its lateral medial condyles, and the patella. Those are the three bones, the articular surface of the patella making contact with the patellar surface of the femur, and the condyles of the femur making contact with the condyles of the tibia. Those are the three bones that make up the knee joint, which is a hinge joint. Of course, articular capsule to form the joint cavity where you find synovial fluid. We have the articular cartilage on the surface of the bones. We also have the quadriceps femoris tendon going from the quadricep muscles to the patella, and then the patellar ligament going from the patella to the tibial tuberosity. We have a number of bursae, including the suprapatellar bursae, the prepatellar bursae, the infrapatellar bursae. Looks like there's only three bursae. Excuse me. So there's three bursae: suprapatellar, prepatellar, and infrapatellar. We also have tibial collateral ligament and fibular collateral ligament. Tibial collateral ligament on the side going from the femur to the tibia, fibular going from the femur to the fibula. And then we have extra ligaments inside the joint capsule. These are the anterior cruciate ligament toward the front and the posterior cruciate ligament toward the back. Again, these are inside the actual joint cavity. We also have two menisci, a lateral meniscus and a medial meniscus. Again, these menisci help to hold the bones in position as well as providing some cushioning. So the knee has a lot of reinforcing structures for its stability. And unfortunately, sometimes the knee gets damaged. Say from a lateral blow to the knee can lead to a damaged anterior cruciate ligament, damage to the medial meniscus, damage to the tibio-collateral ligament. And unfortunately, this is going to require surgery, arthroscopic surgery to repair, because these structures heal extremely slowly and might not fit together on their own, so you have to have them repaired surgically. Articulations. We also have the talocrural joint, the ankle joint between the medial malleolus of the tibia and the talus, as well as the lateral malleolus of the fibula and the talus. It has lots of ligaments, and that's about it. Allows for dorsiflexion, plantar flexion. But here are some kinds of arthritis. We have gouty arthritis, which is when urate crystals accumulate, leading to inflammation, very painful. Osteoarthritis, which is the common form of wear and tear. The joints just degenerate over time. And rheumatoid arthritis, which is an autoimmune disorder. The immune response attacks the synovial membrane, inflaming the joints, leading to swelling, causing bones to get popped out of place, and can even lead to fusion of bones. And that's it for this lecture.